We have two very interesting cases today, which I hope will bring up some interesting point for discussion. I want to remind you all that this webinar is supported by the Clinical Immunology Society, USIDNet, and LACID, which were very helpful coordinating this session, and I want to thank them for that. If for some reason one of you is not a member of CIS, then that's a good time to remind you that you should join CIS because membership is free for a trainee. So go ahead and join us. Generally speaking, we're looking for more cases. So if you have interesting cases, either clinical cases or some cases that will present management challenge, please contact us, and we would love to hear about these cases. I would like to present our speakers today. We have two case presentations that will be presented by Ekaterini Goudouris and Lahari Rampur. We also have two great mentors today, Troy Torgerson and Sergio Rosenzweig, and we'll be grateful for your insight and suggestions. Joyce will start as usual with a brief literature review, so I'm going to turn it over to Joyce, who will tell us about recent papers she liked and will then continue with our clinical cases. So go ahead, Joyce.
Great. Thank you very much. So moving on to our literature review for this particular webinar. So I'm going to present three papers. The first paper is Risk of Infections Among 2,100 Individuals with IgA Deficiency, a nationwide cohort study. So in this study, they identified IgA-deficient patients from about 6 hospitals in Sweden. It basically included patients from inpatient, outpatient visits from a 10-year period between 2001 and 2010. Again, it was 2,100 subjects with about 18,000 age, sex, and birthplace match controls. They excluded other causes for IgA deficiency, for example, CVID. And they also did a second analysis in which they excluded celiac disease because, as we all know, that can be a confounding factor for IgA deficiency. They obtained the clinical data from the Swedish National Patient Register, finding that about 57% of their patients were female. The mean age at diagnosis for IgA deficiency was around 35 years. There was a prevalence of celiac disease at 6.7%, and the majority of these patients were born in Sweden. In terms of the risk for infection, so the studies analyzed the prevalence risk by the types of infections. And interestingly, when they did the analysis, when they excluded the celiac disease, most of these numbers were very similar. They found that the prevalence risk was statistically significantly different in all types of infections that they looked at except for joint infections, with the greatest risk difference in the GI infections as well as sepsis. So the numbers here, as you can see, GI prevalence risk was 3.5, and the sepsis prevalence risk was 3.4. Meningitis was 3.2, upper respiratory tract infections were 3.2, and then a whole variety of other infections that they analyzed, including the mastoiditis, any of the various parasitic bacterial infections that would fall under the ICD-10 Chapter 1 codes. Joint infections and skin infections and UTIs had a prevalence risk of between 1.8 to 2.4. Anyway, so the take-home point from this paper is that perhaps we should be having a higher index of suspicion for other infections in IgA deficiency patients besides perhaps upper respiratory tract infections, which we all know they're more susceptible to, but generally they're generally healthy people. But perhaps maybe some IgA deficient patients may be more risk for other infections as well too. Some limitations from the study included maybe some overestimation because only the patients that would present to a doctor perhaps would be just a symptomatic one, so maybe this may overestimate the prevalence of infections. Also, the authors mentioned that they possibly could have missed a few asymptomatic IgA deficient patients in their control group because those controls were not tested for IgA deficiency. However, another interesting question that would be brought up from the study would be perhaps we might be more likely to prescribe IVIG for IgA deficiency patients who have maybe multiple infections, which I typically don't do. I usually use antibiotics, but perhaps for the more sick or more the IgA deficient patients with more infections, perhaps this may be an argument for that they should be receiving IVIG. So the next paper I want to discuss is the challenge of immunoglobulin G subclass deficiency and specific polysaccharide antibody deficiency, a Dutch pediatric cohort study. So this is a review of cases that were reported to this NSCK database. So it's the Netherlands database that's reported by pediatricians, by general pediatricians. So what they do is these pediatricians actually submit diagnoses of IgG subclass deficiency and or specific antibody deficiency that they diagnose. And then what the authors did is they reviewed the database for the clinical data. So ultimately what they included in the group was about 49 patients, 45 that had at least one decreased IgG subclass, 11 with specific antibody deficiency, and 7 with both decreased IgG subclass and specific antibody deficiency. Of the IgG subclasses, the IgG2 subclass deficiency was the most common seen in this group, and the median age for these patients were about 5.6 years. Majority of these patients were males, and they did note that in the patients that were over 10 years old, almost all of them, not nearly, but all of them were actually boys. In this group, the most common infections were the ear, nose, throat infections, the upper respiratory infections, as well as lower airway infections, and then what they categorize as severe infections such as pyelonephritis and meningitis. Interestingly, about 10% of these kids who had this immunoglobulin subclass deficiency and or polysaccharide antibody deficiency, about 10% actually were diagnosed with bronchiectasis, which is a little bit higher than I would imagine. And these patients are often treated with antibiotics as to be expected, although about 4 were treated with IVIG. In a subsequent follow-up group, which was basically a subgroup of the 49, so about 24 of these patients were seen at a follow-up about 40 months out of after the initial data point. About 19 of these patients had the subclass deficiency, and 5 had either had a subclass deficiency as well as specific antibody deficiency. What the authors note here is about 11 of this 24 had what they call disease progression, meaning that in addition to their subclass deficiency and or their polysaccharides and or their specific antibody deficiency, some of these patients also developed IgA deficiency, total IgG deficiency, or maybe both, or even CVID. And interestingly, all of these were all males. And in this group, in the follow-up group, about 8 were receiving IVIG. So one of the take-home points of this paper was that it reiterates that antibody defects occur pretty often in children, and it can actually persist in some children, as opposed to many children who have minor defects in antibody deficiency, and oftentimes most of those resolve on their own. And some of these children, they may also have associated serious complications such as the bronchiectasis. Some of the limitations that were noted was that many of these children actually did have incomplete evaluations. So only 21 patients sadly only has specific antibody levels measured. So it that could have confounded some of the data analysis. And many of the diagnoses of these specific antibody deficiency and IgG subclass deficiencies were not necessarily confirmed by immunologists. So keep in mind, most of these diagnoses were submitted by a general pediatrician. And, of course, only the symptomatic patients were identified because these are the ones that were presenting to their pediatrician. So that could skew the cohort. And finally, still it's unclear whether, this big debate of whether, what the clinical significance and association of IgG subclass deficiency with these infections is still unclear how they're associated. And then finally, the last paper I wanted to present was the genetic, cellular, and clinical features of ICF syndrome, a French national survey. So ICF syndrome stands for immunodeficiency, centromeric instability, and facial anomalies. So as stated in the syndrome name, these patients commonly have facial anomalies. They have cognitive impairment, which is predominantly seen in the ICF type 1. Many patients have a hypogammaglobulinemia, which can be seen in ICF 2. But the common thing that's seen across the board in many of these patients is that they have no memory B cells. That's a very common finding. It's an autosomal recessive disorder. About 50% of the patients have this mutation in the DNMT3B, and about 30% have mutations in the ZBTB24 gene. So this is basically a detailed study of the clinical and immunologic phenotype of ICF patients. So they included 9 patients from 8 families. These patients were identified through this French PID registry with a mean time to diagnosis of 5.2 years. There were 6 females, 3 males, and you can see the age range in parentheses there. 5 had consanguineous parents, and in terms of their mutations, 7 had mutations in the DNMT3B gene, and 1 had the ZBTB24 gene, and 1 had it in the CDCA7. In terms of the common clinical features, many of the number of them had failure to thrive, delayed growth. There was various levels of developmental delay, as well as facial dysmorphia, and there are interesting various GI problems such as diarrhea, recurring diarrhea, cholangitis, as well as reflux. Most frequent infections that were noted were frequent otitis and bronchitis, with 3 patients actually also having bronchiectasis. And oftentimes the recurring infections were associated with either bacterial, viral, or parasitic causes. So, for example, CMV, herpes, flu, fungal, parasitic, or bacterial causes. 2 patients, interesting, were noted to have some autoimmune features, which is something that was not previously reported. In this group, they noted hepatitis, nephritis, and thyroiditis. In terms of the immunophenotyping in this cohort, again, these patients had across the board no CD19, CD27 positive memory B cells. The patients did have, many of the patients did have hypogammaglobulinemia. However, it was normal in the ICF2 patient. And actually, I have to apologize. Actually, up at the top, the hypogammaglobulinemia is actually more prevalent in the ICF1 patients, not the ICF2 patients. There was no specific antibody noted in some of these patients, nor were there any evidence of IgG class switching. However, they did have normal T-cell response to myogens, but decreased response to specific antigens. All of these patients were treated with IVIG and prophylactic antibiotics. Interesting, all of them also needed iron supplements for anemia. 1 patient, which had the significant autoimmunity, did undergo transplant. However, she died about 6 years later to unknown causes. So this is a very nice review of the major features of ICF syndrome. And the authors did note that they actually identified 6 new mutations in the DNMT3B gene in this particular group. It's a very nice review that delineates kind of the spectrum of the clinical and immunologic features, and perhaps this may help to better understand the immunologic mechanism of other memory B-cell deficient PIDs. So at this time, I will turn it back over to David.
Thank you very much, Joyce. I think these are very interesting studies. I think now we're going to continue with the Lahari Rampur. I just want to remind everyone that on the lower left side of the screen, there is a chat box. So if you have questions, comments, or when we have questions, that's where you can type your comments and we'll try to address them all. So Lahari, I think you can go ahead now.
I don't see my presentation for some reason. Just
here it is.
Oh, okay. Hello, everyone. My name is Lahari Rampur. I'm one of the second-year allergy immunology fellows from Montefiore Medical Center, Bronx, New York. I would like to thank CIS for giving me this opportunity. I'm going to present a case of infantile IBD diagnosed as primary immunodeficiency at age 15. So this patient was evaluated at different institutions till she was 11 years of age. When she came to our institution, she was primarily managed by GI and pulmonary, and we got involved 4 years ago when she already had some immune workup. So she's currently a 15-year-old female with consanguineous parents from West Africa. At 1 month of age, she presented with fever, diarrhea, rectal bleeding, and feeding intolerance. At 4 months of age, she had a colonoscopy which showed patchy pancolitis. She was diagnosed with neonatal Crohn's disease. She developed severe perianal and rectovaginal fistula, intestinal perforation, requiring colectomy and ileotomy within 2 years of age. Her post-op course was complicated by fungal sepsis, pneumonia, and DVT at that time. She progressed with growth and developmental delay. She continued to have recurrent IBD flares despite conventional treatment with daily mercaptopurine, intermittent courses of infliximab, azathioprine, and systemic steroids along with hydrocortisone and methylamine enema. Eventually, she responded to high dose of 6-MP, but she continues to have chronic pouchitis. She's had several episodes of URI, recurrent pneumonia starting from 2 years of age, including recurrent UTI and herpes zoster. And between 8 to 10 years of age, she was found to have severe bronchiectasis of unknown etiology. She underwent a left lingular lobectomy at 10 years of age. She's had recurrent exacerbations and even progressive lung disease since then, and she's chronically colonized with Pseudomonas. Coming to her family history, she's had 2 sisters and 1 brother with Bloom syndrome, which is autosomal recessive condition characterized by short stature, predisposition to development of cancer, and genomic instability. The patient did not have Bloom syndrome. On her physical exam, she is chronically ill appearing. There was no abnormal facial features. She has decreased breath sounds on the left lung field and coarse crackles and rhonchi on the right upper and lower lobes. She has an ileostomy on the right lower quadrant. There was no hepatosplenomegaly or lymphadenopathy.
Thank you, Lahari.
Do you have any questions?
I think we can take a break here and maybe ask the audience what they think of the possible differential diagnosis. I think so far we have very early onset IBD, severe, and also significant history of infection with severe lung involvement. So if you have any suggestion, we'll be glad to see them. Yes, this is a consanguineous family. Somebody asked.
Yes, this is a consanguineous family.
Okay. So we see IPEX. I see IPEX as an option. And if you want to comment on that.
We can.
Another option, GATA2, I guess it's because of the lung involvement. I'm not just sure about the IBD. What do you think about IBD with GATA2?
Could happen.
Okay.
We haven't seen that much at the NIH, but could happen. No.
Okay. CGD, I would say for sure, antigen receptor, likely, very likely. Anything that would suggest one of these options in the history that you would think?
Yeah, so Lahari or me?
Whoever.
So Lahari, what do you think based on these? I think you know the answer, but I think the things here in my mind that are most significant are the early onset, the really severe fistulating colitis that is very resistant to therapy. I think are really, in my mind, the really key points of this presentation that really, I think, should really bring to mind one of these differentials should really bubble to the top with that sort of combination of features. Lahari, one question I had was about the Bloom syndrome. Mm-hmm. So the patient didn't have Bloom syndrome, but do you know by chance whether this patient carried one of the mutations that obviously were in this family? Was she heterozygous for the defect?
No. No. She wasn't really heterozygous for the mutation.
So on the same topic, so how was the Bloom syndrome diagnosed? It was a clinical diagnosis or was it a genetic diagnosis?
It was both clinical as well as genetic.
Okay.
Okay, should I go ahead?
Yeah, I think you can go on with the lab results. Immune workup.
Okay. So in terms of important labs, she did have a normal CBC and lymphocyte subsets, except for chronic anemia. Her mitogen responses were normal. Her immunoglobulins as well as IgG subclasses were normal. The only thing abnormal was MBL, undetectable MBL. She had a normal antibody titers after pneumovax, diphtheria, H influenza, MMR, but she only had a borderline tetanus toxin. Do you have any questions at this point?
No, I think we can go on. Please.
Okay.
No.
Please go ahead.
Okay. He is found to have elevated stool calprotectin at multiple times, multiple situations. This indicates an ongoing bowel inflammation. Our current lab value is 217, which was done a few months ago. ANA was negative, ANCA was negative, HIV was negative, NOT2 mutation was also negative. Her IBD antibody panel was also negative. Neutrophil oxidative burst for CGD was 98% at 48 hours, which is normal. And sweat chloride test for cystic fibrosis was also negative. And hypersensitivity pneumonitis panel was negative.
So Ronnie was asking about NOD2, and that was ruled out. But we have some other questions about history of malignancies in the family. Is there a strong history of malignancy?
No, there was no history of malignancy in the family.
Okay. And regarding the vaccine challenge, she was challenged with unconjugated vaccine, I assume.
Yes, she was challenged with unconjugated vaccine. And it was normal.
Mm-hmm. Okay.
Should I go ahead?
Yes, please.
Okay. Intestinal biopsy from 4 months of age showed colonic mucosa with chronic colitis, crypt distortion, cryptitis, and crypt abscesses. She also had chronic patchy inflammatory infiltrates and acute inflammatory infiltrates in the lamina propria, submucosa, and intramural area. She did not have any microorganisms or parasites. She did not have any granulomas. So this was uncharacterized chronic inflammation of the intestine. On her lung biopsy, which was done around 10 years of age, this was described as an unusual case. Although there was clearly bronchiectasis, many small bronchi and bronchioles were replaced by odd type of fibrosis with epithelial destruction, transition of normal airway epithelium to flattened epithelium, indicating airway repair. So the pathologists were very uncertain how to explain this, and there was a question about toxin inhalation versus ingestion of a vegetable juice called Sarcoma androgynous. But on the whole, the main differentials were post-infectious versus inflammatory. One of the pathologists from Montefiore thought it was infectious, and one of the pathologists from Boston thought it was inflammatory. And there was also a question about lung disease due to 6-MP versus bronchiectasis due to Crohn's disease. So we did consider MBL as a contributing factor rather than a causative etiology. So these were the main differentials at that time. But at this point, the cause of bronchiectasis is unclear.
Lahari, we have a question about plasma cells in the intestinal biopsy. I guess because of the history of infection, mostly lung infections. So we're somewhat concerned about antibody deficiency as well.
I don't think there was any mention of plasma cells in the intestine.
Okay. And again, the antibody levels were normal and good response to vaccine.
Yes. So somebody has asked a question about what Sarcoma is. This is a herb which is used in cooking in Asian countries, and excessive ingestion of Sarcoma androgynous is known to cause some kind of lung disease. And the biopsy initially looked like that, and that's what they mentioned on the biopsy initially.
Okay. Yeah, we can go on.
Okay. So in summary, this is a case of severe fistulizing IBD since infancy, not responding well to conventional immunosuppression, and the colitis was uncharacterized and non-specific. Patient has had recurrent respiratory infection since 1 to 2 years of age, and bronchiectasis by age 10 of unclear etiology till date. All she was found to have was undetectable MBLs, normal immunoglobulins, lymphocytes, and vaccine responses, mitogens, as well as DHR. And she was continued to be treated like a neonatal Crohn's disease till she was diagnosed.
Did these lab results or evaluation change your idea about a possible diagnosis? If somebody wants to bet on a possible diagnosis?
I think somebody already came up with the diagnosis.
I guess that a lot of people came up with the diagnosis, and I guess that the differential has been pretty broad and pretty comprehensive. So, David, do you think that you can recapitulate and summarize all the differential diagnoses that people had made?
I think people mentioned IPEX syndrome, and I think Lahari covered that in another slide. They mentioned LRBA, and I think with inflammatory colitis at the same time, I would also mention the CTLA4. DOC8 was mentioned, NOD2, and IL-10 defect, obviously. STAT3 also came up just now. So,
did anybody mention any of the TTC mutations of the genes that they have been associated with similar syndromes?
Lahari did.
And we didn't think of them because a lot of these patients with TTC mutations will have ectodermal, epithelial barrier defects and ectodermal issues, which we didn't have. I don't think we, pursued that. So can I go ahead with the differentials?
Yes, please. Yes.
Okay, so I'm not going into details of all the diagnoses, but I think it's important to think of the diagnosis in these categories. For example, epithelial barrier and response defect, which happens because of epithelial signaling defects. Dysfunction of neutrophil granulocytes, the common one being CGD. Hyperinflammatory disorders like mevalonate kinase deficiency, autoinflammatory disorders, and even complex defects in T cell and B cell function can also present with IBD. The last one is immune dysregulation. IPEX and IPEX-like syndromes can also present. IPEX-like syndromes as well as IL-10 signaling can present with the IBD. So should I go into the diagnosis?
Yep, tell us. Yep. Please let us know.
Okay. The final diagnosis is IL-10 receptor defect. A lot of people came up with this diagnosis, which is great. This patient had a deleterious homozygous mutation in IL-10 RB gene. This mutation is in the intron 1 splice acceptor site, resulting in skipping of exon 2. And IL-10 is an anti-inflammatory cytokine produced by T regulatory cells, macrophages, B cells, and they inhibit pro-inflammatory cytokines. And the defective pathway leads to intestinal macrophage dysfunction and intestinal hyperinflammation. People with IL-10 pathway defect can have severe neonatal IBD, recurrent URIs, arthritis, folliculitis, and predisposition to B-cell lymphoma. As you see, we did the functional analysis. IL-10 acts through STAT3 phosphorylation. As you can see in the control, addition of IL-6 and IL-10 produce STAT3 phosphorylation, but in our patient, only addition of IL-6 produced STAT3 phosphorylation, but IL-10 did not. So he's currently on.
Sorry. Please go ahead. I'm sorry.
Okay. This patient is currently on 6-MP and also on other supportive treatment. She's undergoing evaluation for bone marrow transplant at this time, but she has severe bronchiectasis with poor pulmonary reserve, which presents challenges to the therapeutic options.
Let me go back here for a second. I think one thing that I like about this defect is the fact that you have a functional assay, so you can stimulate the cells and show that they actually do not respond to IL-10. And I think with many mutations, one of the challenges that we're facing today is actually understand and figure out if the mutation is pathogenic or not. And in this case, you have a very nice functional assay when you can stimulate the cell and check for STAT3 phosphorylation. But I had a couple of questions that I wanted to ask the audience and also our mentors about this case. The thing that and also you, sorry. The thing that I was a bit surprised by is the severity of the lung disease, because it wasn't that clear to me that IL-10 receptor deficiency or IL-10 defect causing severe lung disease. And I was thinking if we are sure that this is the only defect here, especially since it's a family with history of consanguinity, and whether or not we need to look for other defects at the same time. Yeah,
the really troubling thing about this case to me is that the lung disease, because this is not that it can't certainly occur in IL-10 receptor deficiency. It's just not been described. And what's really fascinating about this disease is, despite this being an immunosuppressive cytokine, what's really interesting is that both in the mice and in the humans, really the primary defect that they've got is this really severe IBD, and so I think that's the thing that's really kind of interesting. But lung disease has never been described, and that's why I raised the question earlier about could she be a carrier of Bloom syndrome, of that Bloom syndrome defect that's in the family, because Bloom syndrome, like a lot of sort of DNA repair sort of defects, are often associated with lung disease, DNA repair, telomere defects, and pulmonary fibrosis, and it's oftentimes an atypical lung disease. So like the DKC patients, this pulmonary fibrosis of really unclear etiology. It's not necessarily described in association with recurrent infections, but they get just horrible progressive pulmonary fibrosis that really becomes a major problem. And if she were haploinsufficient for the Bloom syndrome protein, could she get lung disease in the setting of this sort of setup to be sort of hyperinflammatory? Could she? So I wonder whether, that's why I asked about whether she's a carrier of the family mutation.
About it. Very interesting.
Can MBL deficiency, along with IL-10 deficiency, can it cause severe lung disease? Can it contribute? Any thoughts on that?
So IL-10. So the question is MBL deficiency in the setting of IL-10 deficiency?
Yes.
IL-10 receptor deficiency. I don't know. So I'm going to be incredibly biased. I'm going to say something that's probably I will be, people will make fun of me, but my bias is that MBL is a modifier, and could it be a modifier in this case? In my mind, I just don't see it as being a significant enough modifier to cause this degree of lung disease. This is impressive lung disease, and I just don't. My bias is that MBL is a non-disease, MBL deficiency, but that's my bias.
I think we have other people agreeing with you here on the left side. So we have a brief update. Chismar Secundo here tells us that he has another patient with the same mutation and severe lung disease. So maybe that's something that has to do with that. Same splice mutation, similar.
In the same region?
Same region. Okay. And I have another last question, maybe for the mentors as well. When you see a patient with very early onset IBD, what kind of workup or lab test will you order first? Sergio?
Yeah, I guess that you, David, already gave us all the answers. I guess that so our audience is a very well-educated audience, and they thought about most, if not all, of the diseases that they can be associated with very early onset inflammatory bowel disease. So they thought about LRBA. So clearly IL-10 and IL-10 by itself and IL-10 receptor are going to be the main culprits to analyze. But you mentioned IPEX, LRBA, CTLA-4. Docade, I'm not that sure that I have seen enough patients with Docade, and I have seen a good fair of them that they have early onset inflammatory bowel disease, not two that usually presents as Blau syndrome, so not in the adult form that we see kind of Crohn's disease like. And then the TTCs, I know that the TTCs, both the 37 and the TTC7A, so they have different form of presentations, but they can present as very early onset inflammatory bowel disease. Not necessarily with the fistula that this patient had, but whenever you have a patient, keep in mind that those are new diseases, and we don't have seen enough number of cases to know all the spectrum of clinical presentations. So I will still consider them a possible diagnosis whenever you have patients with very early onset. Keep in mind that this patient started within the first month of life. CGD is another one. So I guess that at least the ones that we are over 40, I will not ask who is over 40, have seen enough cases of CGD and enough number of cases they presented with inflammatory bowel disease. What about you, Troy, that you're going to turn 50 this year?
Yeah, yes, definitely some cases of CGD. You know, the one disorder that did not get raised on this that could definitely present with early onset disease. Now, she's a female, so that not so much in this case, but is CIAP deficiency, which I think is one that didn't get raised. You know, I think when I think about early onset bowel disease, I sort of try to break it into two compartments. There's the patients who have angry, very sort of inflammatory colitis that sort of has a very innate feel about it. A lot of times the mucosa is very friable. It's very bloody. A lot of times with, they go in to do biopsies and it's just very angry, inflammatory looking. And the disorders I think of with that are, IL-10 receptor deficiency, IL-10 deficiency, CIAP deficiency, CGD, the colitis we see in XLA a lot of times has that sort of very angry, inflammatory. And then on the other side, you have the colitis, the early onset colitis that's more like it's more like an autoimmune enteritis. So basically, it's just profuse watery diarrhea because of either lymphocytic infiltrates in the bowel or because of villus atrophy. And so those are like the IPEX, the CTLA4, the LRBA, where it's not so much angry, friable mucosa. It's really more like a malabsorptive, watery diarrhea. Very rarely is it bloody, and so you can kind of break them into two different groups, and that can sort of get at least as an initial pass to sort of think about which gene defects might you think about in this group. You can kind of, I think, divide them in some ways that way. Angry, friable mucosa, fistulating versus sort of watery, profuse, watery diarrhea. And it kind of gets you in two different groups of genetic defects in some ways for your initial workup.
Well, thank you very much, Troy. I think we need
So one last question. Lahari, how was the IL-10 receptor defect found? So it was whole exome, whole genome, just candidate gene. So how did you do it?
That was just a candidate gene. So
Smart people.
One of the interdisciplinary meetings, everybody sat together and, allergy immunology as well as GI came up with this idea of testing for IL-10 mutation, and that particular gene was sequenced.
That was a smart approach, but I guess that I will also take into account Troy's suggestion that, that we tend to believe that patients come with just one disease, but sometimes they have something else, and especially when they have kind of weird phenotypes. So it's not abnormal. Mm-hmm. If you look at people that they do a lot of whole exomes, they found like up to 4% of the population, they have two genetic diseases at the same time. And 4% means 1 every 25. So it's not that rare. So whenever you find a patient mm-hmm. like this one that fulfills the clinical diagnosis for one disease, but has something else or extra, you might think that they might have some other extra genetic information providing the explanation for the unsuspected or not that clear clinical manifestations.
Mm-hmm. Thank you very much. I think we have very interesting points here, and we still can keep going and discuss this case, but we need to move on to the next case. So thank you very, very much, Lahari. We're moving to the next case, which is kind of on the other end of the spectrum with late onset immune problem or kind of immune problem. So I would like to welcome Dr. Ekaterini Goudouris to present her case. If we can switch slides.
Presentation.
That would be great. Thank you.
Okay. Hello, everybody. My name is Ekaterini Goudouris. I'm an allergist and clinical immunologist from Brazil. I'm a professor of the Department of Pediatrics of Federal University of Rio de Janeiro. And I will present you a case of a male patient, now 65 years old, who I saw for the first time in early 2012. He was referred to me by his hematologist due to a history of recurrent Kaopsi, sarcoma, and lymphopenia. The history is that in 2000, skin lesions and lymphadenopathy appeared, and the diagnosis of Kaopsi sarcoma was made by biopsy. The first and only CBC before the start of treatment to which we had access already showed lymphopenia. This is very important. He was treated with alpha-interferon for 6 months, followed by thalidomide for another 6 months between 2000 and 2001 with good results. But 1 year after completion of this treatment, there was recurrence and appearance of new skin lesions and lymphadenopathy, but there were no important clinical consequences, so the patient received no treatment at that time. But later on, skin lesions in areas such as his feet began to cause discomfort, and the patient was treated with peg-doxorubicin in 2014, and at the end of 2015 with paclitaxel. In his past medical history, there's no report of bacterial, viral, or fungal infection, severe or recurrent. He had one acute otitis media with perforation in 2001 during the period of treatment. He had also a few episodes of uncomplicated herpes labialis and 2 surgical procedures without any complications. No previous neoplasias, no autoimmune disease, and he has 2 healthy adult sons without lymphopenia, but both of them have recurrent warts since childhood. On his physical examination, he is in good appearance. He had skin lesions compatible with Kaopsi sarcoma and some palpable adenomegalies, and just that. I've been following this patient since 2012 until now, and it's noteworthy that during this time he presented viral infections without severity when he was not on chemotherapy, but he had 4 acute otitis media in 2014 and 1 episode of zoster in 2015, all of them during chemotherapy. Some tests were carried out in periods when he was not receiving chemotherapy. I selected the results from periods he wasn't receiving any drugs for at least 6 months. And the results were lymphocytes between 594 and 1095, normal neutrophils. There's no evidence of HIV or HTLV infection. IgG ranges from 593 to 770, normal IgG subclasses, IgM between 76 and 94.8, IgA between 31.9 and 41.8, CD4 lymphocytes between 380 and 542, CD8 cells between 42 and to a maximum of 93, CD19 lymphocytes between 12.8 and 14.4%, and NK cells between 105 and 148. Immunophenotyping of bone marrow aspirate revealed a similar distribution of lymphocyte subpopulations. We also performed the delayed type herpes sensitivity test with a small response to candidin and tetanus toxoid and with no response to PPD, and he has not received BCG vaccine. At the time, there was no routine for BCG vaccine in Brazil. In vitro lymphocyte proliferation assessment was performed, but with CSFE, because we did not have access to evaluation by tritiated thymidine at that time. The proliferation of CD4 lymphocytes was normal by this test. We don't know, we can discuss a bit about the validity of this, but it wasn't possible to evaluate the proliferation of CD8 lymphocytes due to the small number of cells. ADA and PNP activity were normal on tests performed by courtesy by Michael Hirschfield of Duke University. We identified positive IgG for measles, rubella, toxoplasmosis, EBV, and zoster, and negative IgG for CMV, C. hepatitis V, B. hepatitis V, despite being vaccinated, and also negative for tetanus and mumps. He was vaccinated again for tetanus with insufficient response. We also identified response to unconjugated 23 serotypes pneumococcal vaccine with values about 1.3, above 1.3, only for 3 serotypes of a total of 7 serotypes tested, noting that at that time we only had access to 7 serotypes dosage. We didn't have the exam for more serotypes. In summary, this is the case of a 65-year-old male patient with recurrent but easily responsive to treatment classic Kaposi sarcoma for 15 years, with no significant history of recurrent infections, neoplasia, or autoimmunity, normal to low immunoglobulin levels, B and CD4 cells count, with abnormal vaccine responses and very low CD8 levels, cells. I think it's important to note that it seems to be a stable immunologic profile. He's not getting worse. The CD8 count, for instance, is not decreasing anyway. So, what are the possible diagnosis? That's. Do you think we can stop here to discuss a bit?
Maybe a few questions that people were asking. Okay. Do you have anything about his monocyte?
Sorry, I didn't listen to you.
Any data about his monocyte count?
No, they were normal. I can search for that, but they are normal. Okay. Normal levels, absolutely normal. The other cells are absolutely normal. No great eosinophils, no normal neutrophils. A little bit above levels because of the low lymphocytes, but
people are mentioning DOC8, and I was wondering if you checked his IgE level.
IgE? No, it was normal IgE. It was just below 10. And more than one time.
Another thing you mentioned, all these lab results were done either before or long after the chemotherapy, so we can blame chemotherapy.
Yes. Okay. Of course, we have results from the periods of chemotherapy, but I selected only the results in which he was not receiving chemotherapy.
And his children were normal, except for the warts, other CBC, everything was normal.
And no neutropenia.
Did any history of neutropenia in the family?
No neutropenia. Just a little lower, below 1,500 just during the chemotherapy, but never more.
Okay. So, Ekaterini, one question regarding the Kaposi sarcoma. Did they find any viruses? Did they do any in situ hybridization for herpes virus?
I was not following him at that time, but he came with a result that he has a positive human herpes virus 8. It was documented but I wasn't following him at this time.
Good.
So I think I had several questions or several points that maybe you can address. I think regarding the differential diagnosis, people are already mentioning, and I would like to split it into two different questions. One of them, do we know any specific defects that are causing CD8 or low CD8 levels? Is there such a thing similar to CD4, like idiopathic CD8 lymphopenia?
No, yes, that's what we're going to discuss the next slides. I don't know if I must go on.
Please go ahead.
Okay. So we consider the following possibilities: secondary immunodeficiency due to chemotherapy or due to infection with human herpes virus 8, or as a part of Kaposi sarcoma picture. A consequence of a process of aging of immune system, or a primary immunodeficiency with late onset. Given the low CD8 values and the presence of Kaposi sarcoma, we consider the possibility of CD8 deficiency, mutation of ZEP70, or of STIM1. And the next slides, I will mention here the most important points for discussion regarding these diagnostic possibilities. We rule out the possibility that this is a result of the treatment, since lymphopenia and CD8 deficiency were maintained in long periods without this type of medication. Besides that, we haven't found reports of CD8 deficiency with immunosuppressor, particularly with the medications the patients received. So we rule out that. Then the patient apparently has a classic Kaposi sarcoma. That is a clinical condition that we already know evolves as an indolent disease in elderly adults without any immunodeficiency. However, in this case, the disease began at the age of 50. It's a little bit too early for the clinical condition. Besides that, we also didn't find CD8 deficiency reports in patients with classic Kaposi sarcoma. So it's not a good hypothesis. We also didn't find reports of CD8 deficiency in patients with human herpes virus 8 infection without Kaposi sarcoma. However, there is evidence that CD8 cells are important in controlling the infection by this virus and also in the prevention of the appearance of disease when the patient is infected with the virus. So there is a possible relation there. Going forward in the process of immunosenescence, there is description of low CD4-CD8 ratio and functional changes of these cells. However, we haven't found CD8 deficiency reports. Besides that, it's noteworthy that in elderly patients, seropositivity for CMV is related to poor vaccine response, that the patient has a poor response to vaccines, but this patient is negative for CMV. He has no positive serology for that virus. And regarding a possible primary immunodeficiency, I want to point that CD8 deficiency cases are described, and they were related to severe respiratory infections, and I found no description of Kaposi. But it is very interesting to note that there are reports of sisters of these patients who also had CD8 deficiency but were asymptomatic at the time of the description of these cases. But we don't know how these individuals are evolving over the years. At least I couldn't find this report. So perhaps it's an interesting point to search here. STIM1 defects are related to Kaposi sarcoma and clinical conditions that reveal immunodysregulation, but we didn't find also any report of CD8 deficiency in these patients. There are reports of Kaposi sarcoma in patients with WHIM, but these patients with WHIM have also warts, hypogammaglobulinemia, lymphopenia, with B-cell deficiency and peripheral neutropenia due to myelocathexis. So it doesn't fit. Hypomorphic mutations in ZEP70 have been described with low levels of CD8, normal values of CD4, a loss of its function, a lighter clinical picture, late onset. But here again, we didn't find reports of Kaposi sarcoma in the cases described in the literature. So finally, I think we cannot rule out the possibility of another immunological defect not on net, or perhaps it's just a coincidence. I don't know. And that's all. Thank you for your attention.
Thank you very much, Ekaterini. And I have a few questions about this case. I think one of the first questions that I had, is it or not an immunodeficiency? I mean, Kaposi sarcoma is something that you can see at this point. So I was wondering if that by itself should trigger some evaluation or suspicion for immunodeficiency. But obviously, we have the other component here of low CD8 count. So I have a more general question, maybe to our mentors. When would you suspect a primary immunodeficiency in the older age group, especially now that we have all these, we know about haploinsufficiency and hypomorphic mutation? What will make you think about immunodeficiency in the elderly patient or the adult patient?
So Troy, you want to start?
Sure, I'll start. So I guess I'm not sure that it's really that different than in a young patient, really, in terms of the, it gets back to too many infections, unusual infections that are, that normally should not appear in that age group, or are odd for the patients, or weird autoimmunity. And I think one of the things that I think we can't rule out in these older patients is the idea of somatic mutations, which we know occur and can cause certain types of immune deficiencies. Certainly somatic ALPS and there's now somatically, described somatic periodic fever syndrome defects. I would, I'm certain that we are going to find more somatic defects as we do next generation sequencing in some of these older patients that cause some of the presentations that we see in younger kids. So I think, again, I would use similar criteria that I do in younger patients. Serge?
Yeah, I completely agree. I think that this patient had too many Kaopsis, sarcomas, and actually he has some other signs of immunodeficiency, and he's lymphopenic. He's an adult. We are pediatricians who are used to 2,000, 3,000, but this guy has 300 CD4s and at the max of 100 CD8. So he is lymphopenic. So the surprising thing is that most of his infections are restricted to the skin. So now we know that there are those diseases that affect every aspect of the immune system and make us susceptible to every type of microorganisms. But then we know that there are some others that are susceptible to very narrow kind of microorganisms or tissue specific. And we know that patients, for example, with blockade, we know that lymphocytes, they cannot reach the place that they need to get in the skin in order to control viral infections. So it's very surprising that this patient only had herpes 8 kind of mediated disease and everything restricted to the skin. I think that this patient is going to be a great candidate for a whole exome sequence or even whole genome, also considering what Troy have just said. So somatic mutations have to be also considered, especially in patients that have been healthy most of their life, but then they start having mutations. And as Troy just said, so we know that that happens in patients with primary immunodeficiencies, but also autoinflammatory syndromes. So this is something that we have to keep in mind because it's something that's going to appear more and more frequently.
Thank you. And I want to mention other diagnoses that other people mentioned here. And Ekaterini, I think that Dr. Condino offered to check TLR response because of the recurrent viral infection. So you can send him a sample, and I don't know if surgery is willing to do whole exome sequencing on the patient, but maybe we can check with him as well.
You have Bosco there, so you have Bosco in Brazil, so if Bosco refuses, we can discuss it. So one other gene that has been already described associated with Kaopsi, it's the OX40 by John Oran's group. So there's a narrow group, but it does exist, group of genes that they have been associated with Kaopsi. So I know that you have read the literature. So there are some options, and I like the idea that Troy brought to the table about the somatic mutations. But I guess that whole exome going to be the way to go in this patient because I don't think that by candidate gene we can find anything.
Okay.
And then, so you mentioned OX40. I think that's a very interesting case, and it was described with early onset Kaposi sarcoma. And people.
You see, David, you just asked me to do the exome, and Condino just replied very fast that he's going to do the exome, actually, even with capital letters.
So maybe you can do both and see who can find the answer first.
Exactly. No, I'm fine. I know that Condino is better than us, so no. I'm going to let him do it.
Okay. Just want to mention, people also brought up the NK dysfunction, and I guess trying to suggest GATA2 because of the lymphopenia and the viral infection. So I think that's another option worth mentioning.
Yep.
I was just saying NK DOC8 deficiency has been described too. So.
Yep.
So I think thank you very much for everybody who participated today, and I would like to also thank Joyce and Chandra for helping coordinating this session, and thank you very much for attending. It was fun. So see you next time.
Okay, thanks very much.
Thanks, everyone.
Thank you.
Bye-bye.
Thank you, guys.
Thank you.
Okay, any comments?
Just by Condino. He might have